Thank you all. It's a pleasure to be talking to you. I wish I could be with you in person, but I was very grateful for the invitation to talk. So I'm talking about intrahepatic cholestasis of pregnancy, which I think most of us colloquially, if I can speak, know of as obstetric cholestasis. But actually ICP is the sort of international correct term to use, and you'll be seeing it coming more and more into the literature, into guidelines. So I'm going to call it ICP forever on in, I hope. So I think when we talk about cholestasis of pregnancy, we're generally quite familiar with this picture, a patient who has this intractable and severe itch. And we typically describe the classic itch as being on the palms of the hands or soles of the feet. But actually, the itch can be anywhere. The severity of the itch can be very mild, or it can be really very distressing. And women will present in different ways. And I think that's one of the important things to understand about cholestasis, is that different presentations will occur for different women. And the presentation doesn't always reflect the severity of the condition. So how is it defined? Well, we talk about pruritus in combination with a deranged liver function. So elevated bile acids is the definition really of cholestasis. And also in the majority of women, but not all, they will have raised liver enzymes, so particularly ALT. In the UK, it affects about 0.7% of pregnancies. And there is some variation internationally, and particularly within different populations. So women from South Asia, Chile, Scandinavia are at somewhat higher risk of cholestasis. Now, we know that it seems to be higher in women with, essentially, I would like to say, kind of more hormones. So assisted fertilization rates seem to be higher, and particularly multifetal pregnancies. There is a seasonal variation. So in the winter time, women seem to present with more cholestasis. Whether that's associated with vitamin D isn't yet clear, but there is a suggestion that may be there. But particularly we do see higher rates in women with hepatitis C. And of all of the viral illnesses of the liver, hepatitis C is the one that's coming out, predisposing women to then develop cholestasis. So why does cholestasis happen? Well, it's a combination of the hormonal environment of pregnancy, and we think it's, rather than the absolute number of sort of concentration of hormones, it's how the body breaks down the hormones, how the metabolites of these hormones will put a woman at an increased risk if she has higher rates of some metabolites. That combines with the environment, so selenium deficiency has been implicated, and this seasonal variation. And then this is on the background of a genetically susceptible woman. So different women will have different genetic susceptibilities. It's not usually a monogenically inherited condition, but slightly different presentations of their genetics, particularly in bile acid transporters, will put a woman at an increased risk. And so it's a combination of these three factors will drive a woman to develop cholestasis. Now, these are our maternal implications. So you can see, whilst we describe cholestasis as an itch in the absence of a rash, what you will often see is this excoriative rash. Women might have the sleep disturbance associated, so particularly they describe the itch being worse at night, and the fatigue associated with cholestasis can be quite severe. The anxiety we'll talk a little bit about later, but the fear that comes from a diagnosis of cholestasis, particularly if you read online that it's associated with increased risk of stillbirth, is a huge symptom for women. And then we look at the sort of more medical implications, so hepatic impairment, the risk of maternal biliary tract disease. About 20 to 30% of women will have gallstones. The gallstones don't cause the cholestasis, they don't make it worse, but it's the same genetic change that puts you at risk of cholestasis, is also the same genetic change that puts you at risk of gallstones. And then there's good evidence now that women who have cholestasis are more likely to develop gestational diabetes and have a higher chance, about threefold increased risk of preeclampsia. Now, why do women itch? You may remember I said earlier, the severity of the disease, the extent that the bile acids go up, isn't related to the degree of the itch. So the intensity of the itch isn't caused by bile acids. We think there are two possible causes. One are these sulfated metabolites of progesterone, so the breakdown products of progesterone. And then there's something else called lysophosphatidic acid, which is produced by an enzyme called autotaxin. And autotaxin concentrations are higher for women with cholestasis. Now, what these women worry about, this anxiety, is mainly related to the perinatal outcomes. So there are some suggestions of higher rates of fetal hypoxia. Certainly there are higher rates of meconium staining, and that's probably because bile acids enhance the contractile activity of the smooth muscle of the bowel. So it's not the fetal distress causing meconium passage, but it's actually the direct impact of bile acids on the intestinal mucosa. Preterm birth is a big risk, and then intrauterine death, stillbirth, is what women worry about. When you look back at the original studies of cholestasis back in the 1970s, there were a couple of studies that have really taken hold in some of the international sort of reports, and that was looking at the condition when it was described by jaundice in pregnancy. And in these two small studies, they reported stillbirth rates of between 10 and 15%. Now that's really quite shocking. And if you're a patient that comes across this study and says that you have, a 10 to 15% chance that your baby will die, then you can understand why it's a hugely anxiety-provoking condition. However, if you look at more recent studies, some have said there's no increased risk of stillbirth. Some have said up to about 3.5%. And it's very difficult to power a study to get enough patients recruited to really work this out. But because of this fear of stillbirth, the concept of active management of the condition has come in there. And active management can mean many things. It can mean intensive monitoring with repeated ultrasound scans, regular CTGs, early delivery, so preterm birth. But it's very difficult to say if that's beneficial if we can't even quantify the risk of the condition. So what we did a couple of years ago is we looked at all of the different studies that have been reported on women with cholestasis. And we wanted to really try to quantify what's the risk of the condition and which women are at risk. So when we just took data that was published and we compared it with women with uncomplicated pregnancies, there was no increased risk of stillbirth. You can see it's green. The odds ratio, or the chance that there was any difference, any higher rate, included 1, which means there's no difference. There's no increased chance of cesarean section, low APGAR scores, or a difference in the baby's birth weight. However, when we did look at the data, there was an increased risk of preterm birth more than 3 times. And that's both a spontaneous preterm birth, going to labour naturally, or with a doctor's induction typically. And women do have their babies a little bit earlier, about 1.5 weeks earlier. Their babies are more likely to go to the neonatal unit. And as I said, meconium staining is at a higher rate. But that's quite generic data, and that doesn't let us work out which women are at a higher risk. So we took individual patient data, so results from every individual woman from all these countries across the world. And what we found is that there is an increased risk of stillbirth as your bile acids go up. Now this is a ROC curve, and it basically shows the red line are your bile acids and your chance of stillbirth. And anything closer to a sort of straight line up and across means that it's a good predictor of bad outcomes. If it goes along the middle, which is your liver enzymes, then there's no difference from chance. So liver enzymes have no predictive ability to tell you if you're likely to have a stillbirth, but your bile acids going up do. Now that isn't the easiest thing to understand, but when you plot it onto a bar chart, you can see beautifully that the red bars show the chance of stillbirth as your bile acids go up. And you can see as your bile acids are over 100, the red bars suddenly shoot up to having a risk of about 3.5% that you might have a stillbirth. If your bile acids are below 100%, the risk is no different from the background population. And this is looking at the peak bile acids. So the highest your bile acids ever are, if they're over 100, you have nearly 3.5% of those babies will be stillborn. So that really helps us identify which women are at high risk. When does this stillbirth happen? Well, this kind of just shows the risk of stillbirth over time. And the red bar with this little arrow are the women who are at the highest risk of stillbirth, who have their bile acids over 100 at any point. And this increase in the chance of stillbirth seems to happen sometime in the 35th week. So that's the logic behind recommending an earlier birth for these babies. Now, why does ICP cause stillbirth? Well, there's two theories. One is that it's because of a bile acid affecting the heart, causing an arrhythmia. So this picture looks at a cell-based kind of petri dish of a mock-up of a baby's heart. And you can see that if you add bile acids to that heart, rather than having a normal contraction, which you can get in a petri dish of lots of cardiac muscle cells, if you add bile acids, suddenly they get this kind of re-entry tachycardia and incoordinate contractions. We've also seen in the placenta, if you add bile acids to the placenta, you get contraction of the placental vessels. And that's what the graph on the right shows. That shows as you get higher bile acid concentrations, so your muscles contract around the vessels in the placenta. So placental vasospasm may be why these babies die. Both of those things can't be predicted. So an ultrasound scan is not going to tell you if your baby is likely to develop a sudden arrhythmia later in pregnancy. It's not going to tell you if you're going to develop sudden vasospasm, and neither is electronic monitoring. So whilst many women are recommended that they come in for growth scans or CTGs, and they're reassuring at the time, they don't predict which babies will be stillborn. It's only the bile acid concentration that can help. Now, I mentioned earlier, it's not just about stillbirth. What about preterm birth? So as you can see, this is a very similar picture with a few more lines, but the important thing is looking at the red bars. As your red bars go up, your preterm birth, your overall preterm birth risk increases. That one doesn't have a threshold. I think it's reasonable to say any baby where the mum has cholestasis does have a higher chance of preterm birth. Often that's iatrogenic, so that's a doctor telling a woman that they must have an induction of labour. And you can see these women are not at a higher risk of stillbirth, yet we're still recommending that many babies are born preterm. And I think that's something that's really important to change. So the next thing we want to talk about is what treatment should we use? And many of you may have worked in units or recruited patients in those units, and thank you for that, to a big study, a big clinical trial of ursodeoxycholic acid, which is I'm going to call URSO or UDCA, compared with placebo for women with cholestasis. That was the PICTURE study, and that was reported back in 2019. And that was the biggest study of any treatment of cholestasis that's been performed in the world. You can see where the women were recruited from, an awful lot from the Midlands. And the primary outcome that the study team looked at was a combination of stillbirth or neonatal death, preterm birth, and admission to the neonatal unit for more than 4 hours. And what they found was that URSO did not reduce this composite, any one of those things, compared to placebo. You can see that big diamond at the bottom crosses the kind of main line in the middle, which is no impact. And when the diamond does that, they looked at all the different groups, so women with lower bile acids, higher bile acids, earlier gestation, later gestation, singletons and twins, and there was no significant difference for any of those groups. So we couldn't say at the end of this study that URSO improved this composite outcome. So should we use URSO? I'm sure many of you have still heard that we are using it in a variety of places. Now the Cochrane review looked at all of the previous studies, and that found a few things. So there was a significant reduction in itch, but it was a very small amount, by about 5%. So yes, URSO can improve itch, but for many women, it will have minimal impact. Some women, the itch may have reduced anyway. So it's worth considering and offering, but it is giving medication in pregnancy that a woman might not wish to take. And you can't promise a woman it will magically improve her itch. Unfortunately, it might improve it by a small degree, but it's not likely to be a sort of magic fix for itch for most women. It does reduce a woman's transaminases. So although the transaminase, the ALT, isn't associated with stillbirth, it's still quite worrying to see big numbers up there. And if you give urso, your numbers will look a bit better, but you're treating numbers and you're probably not actually affecting the pregnancy itself. And then preterm birth, well, the way that it was reported was that there wasn't a significant benefit with urso treatment because the quality of the studies wasn't good enough to be able to say that. It was just significant, but if you have a look at the bottom, it says there's low certainty evidence. So the overall sort of feeling after the Cochrane review was that there wasn't a lot of benefit. Here's what it did to bile acids. So urso is in red, placebo is in blue. And what you can see is bile acids fall whatever treatment you take for women with severe disease, typically within the first week. And urso isn't the responsible for this fall in bile acids for the majority of women. So is urso obsolete? Should we bother using it? Well, what it does do is it changes composition of the bile acid pool. So here we looked at women's blood tests and we looked at all the individual bile acids that make up your total bile acid result. And what we could see is that women taking urso, about 60% of their bile acids were made up of urso. So we got rid of lots of the toxic ones and replaced it with healthier bile acids. And there are a variety of studies that have suggested it may help with the fetal heart and also with the placenta. So we looked at a new study where we again did like we did before, we combined all of the evidence from all of the studies. And what we found is that actually taking urso in singleton pregnancies does reduce your risk of spontaneous preterm birth and a combination with stillbirth if your bile acids are over 40. So here's the picture that sort of is the really clear result. There's no difference in the rate of preterm birth if your bile acids are always below 40, but if your bile acids go above 40, then taking urso reduces the chance. It doesn't eliminate it, but it reduces the chance of you going into preterm labour. So I do recommend giving women with earlier onset and bile acids over 40 urso treatment. Now, the next thing that we sort of wanted to talk about is when should we diagnose ICP? Because what we know is that when you eat, your bile acids go up. Here's a study where we gave women lots of standard food and then measured their bile acids over time. And you can see at the beginning on the left side, they had much lower bile acid levels, and then they went up with food and over the course of the day. The bottom two groups shows that happens for women whether they've got cholestasis or uncomplicated pregnancies. And it makes it very difficult to work out what our definition should be. So in the past, you sort of use a normal range and try and say, well, we'll take the top part of that and we'll say that's abnormal. But bile acids aren't normally distributed, so you have to do a little bit more thought. But actually, when we looked at the bile acid concentrations for women with normal pregnancies, we calculated that if it's non-fasting samples, we should really increase our definition of cholestasis to be about 18 to 19, and another recent study has shown 20. So I think in non-fasting samples, we shouldn't be diagnosing women with cholestasis when their levels are below 19. That could be normal increase just with food. But for women with more severe disease, we should probably offer them urso. Now, very quickly coming to the end, what should we do? Well, if you look at on the Royal College of Obstetricians and Gynecologists website, you'll see that the current green top guideline that gives us advice was published in 2011. So it's completely out of date. All of those studies I've just talked about are new and they're not included. And they've said on there for quite a long time that the third edition of the guidance is in development. Well, that doesn't help our patients that we're looking after right now. Other guidelines have incorporated some of this evidence. So there's US guidance, there's European guidance, and there's also within the maternal medicine guidance released during COVID in the Royal College, a little inference to some of the differences in how we should manage people. But my advice is really to ask the experts, and I work very closely with ICP Support, which is a UK-based charity, but it has international, it is very happy to sort of support women internationally as well. And Jenny, who runs the charity, is also a researcher within our group. So she really gives evidence-based advice and guidance, and they produce, they have a guideline online that you can access through here. But what's really interesting is if you look at the impact for patients, and actually by giving evidence-based guidance, advice to patients, it really is improving their pregnancy care better than these out-of-date guidance that we really do need to update. And I hope in the next year we will see are improved. I work with an awful lot of people. I've just put some names up here of my many collaborators. But I think what I'm really happy to say is if there's any, if you ever have a patient that you've had with cholestasis and you do want advice, Jenny in the charity or me personally, I don't mind being emailed at all. If you do have something difficult, please ask, reach out. Many doctors don't really know a great deal about cholestasis, and actually it's the midwives who are interacting with patients who are the women, you know, they're the way that patients present, and you're very often their advocate. And I work with brilliant midwives in my unit who I'm really happy to support with looking after patients, and please do contact me if you do want any advice as well. I'm happy to talk to you or whoever your colleagues are. So I think Paul has come up because it's question time. So if you have any questions about cholestasis, please ask. I'm very happy to answer.